Hello, everyone. Another conversation webinar hosted by the Cyprus Medical Society of the UK. I'm Nicholas Galazis, one of the co-presidents, and with me are two committee members, Ifigenia Mandrali and Miria Galazi, who will be leading the questions today. This webinar is very special to me, as we will be discussing with a distinguished clinician whom I've had the pleasure to work closely with for the last for 2 years. Professor Christina Fotopoulou is a consultant gynecological oncologist at Queen Charlotte's and Chelsea Hospital in London. She trained in obstetrics and gynecology at the famous Charité University Hospital of Berlin and subspecialized in gynecological oncology at the same place. At the Charité, and before joining Imperial in London, Professor Fotopoulou was the leading consultant and vice director of the Clinic for Gynecology, one of the largest accredited centers for gynecological cancer in Germany. She has also been the principal coordinator of the European Competence Center for Ovarian Cancer, which was created in 2007 in Berlin. Her principal area of clinical practice relates to ultra-radical or excentrative surgery for advanced and relapsed ovarian cancer, and in general, advanced gynecological cancer. Professor is the author of over 180 publications. Among her research projects, she has investigated the implementation of targeted therapies in advanced gynecological cancers and their implications on surgical practice. She has broad experience in national and international clinical and surgical trials in gynecological cancers, and is involved in the German, British, and European committees, guideline development committees for ovarian cancer. Professor Fotopoulou lectures regularly at national and international fora. She's often that personal international conferences that delegates will want to hear and attend her session most. And I'm sure we shall all see and understand why. I've had the great luck to be with her in the operating theater on multiple occasions. For me, and I say this very responsibly, she is technically the most gifted surgeon I have ever seen. She's also an extremely empathetic clinician, one that deeply cares for all her patients. I can go on forever, but I will stop here. Professor Fotopoulou, dear Christina, thank you for accepting our invitation. I'm looking forward to a nice conversation.
It's my pleasure, my honor. Thank you for your words, and it has been a great pleasure to work with you in theatre and to have you taking care of my patients. So, and it's also a pleasure to have so many patients from Cyprus, also from Greece, who come to London extra for us. So that gives me always strength. I love my Cypriot and Greek patients the most, if I'm allowed to say that.
Just before I hand over to Effie and Miria, we just a quick outline of the conversation today. I think we're going to talk about very briefly about training and your career pathway in Germany before you arrived in the UK, and subsequent to that, we'll talk. The main topic will be the management of ovarian cancer, and we're going to talk about surgical techniques, but as well as targeted therapies, genomics, and so on. So, without further ado, I think Effie will start with the questions.
Professor, great to have you. It's a real honor, like Nicholas has said. Let's start off by maybe you telling us how you decided to follow this career pathway.
That is a very good question. So my father is a surgeon. He's a general surgeon. So I was brought up with discussions around surgery, drains or abdomen. So it was something very familiar to me. And the first time I attended theatre was when I was 12. So I remember I studied in Germany, but we were obliged during our training to do some electives in other hospitals just to see how the nursing works and how other systems work. And I remember I went on the second year of my medical studies to the University of Athens, the Alexandra Hospital, which is the largest cancer center in Greece at this time. And there were so many ovarian cancer patients with big abdomens. That was like, I don't know, 25, 30 years ago. Yeah, big abdomens full of cancer and ascites. And 20, 30 years ago, we didn't really have all this that we have to offer them now. And I said, I want to work with those patients to make them feel better. That's how I started to choose and to have my first mind to go to gynecology.
So following on from that, we want to hear a little bit about how the training as a gynecological oncologist in Germany is structured, and also what is, in your experience, the main differences with the same training that we're receiving in the UK. A lot of new trainees thinking about gynae-oncology are wondering what path to follow. How do we obtain the breadth of experience in the current climate in the NHS? Is combined training something that we ought to be considering? And also, what challenges is the specialty facing?
Yes, so there are very fundamental differences in the training in the UK and in Europe. I'm saying Europe because the training in Germany is the same approximately like in other countries. So the main difference is that as a trainee in the UK, you are not employed by the hospital. You belong to a deanery, and this deanery sends you to different hospitals to do different things. Yeah, so your boss is the deanery practically. Yeah. Whereas and then you go a few months in one hospital, a few months in another hospital, etc. So when in Europe, for example, in Germany, you apply like for a job, like for a normal job, you apply to the chief of a hospital. You go, for example, to the chief of the hospital, was the Charité, and I went to him and I said, hi, this is my name. I just finished medical studies. I want to do my training of obs and gynae here. And it was me and I don't know, 50 other people, and they were all interviewed. They chose me, and I stayed there for 6 years to do my training. So when you do that, then by learning more a department, of course you can do more on the problem is that of course you don't see any other practices. So I only knew how everything is being done in one hospital, whereas the trainees in the UK, they go to various hospitals. On the other hand, when you stay with one team for so many years, of course you get more acquainted with the team, you can do more in theater, you can choose. So I did obstetrics for 2-3 years, and then I said that's not for me, and I went to gynae-onc, and practically then I said I'm not really interested in IVF, so I never did really a lot of IVF, whereas here you have to do the IVF even if you don't really want to. So it's a bit different the way everything is shaped. Also the difference is that in the here everything is very obstetrics oriented.
Yeah.
Yeah, whereas in Europe you can choose more where you would like to go. Yeah, these are the main differences.
And just before we move on to your specialty as such, any suggestions on how we can improve training for us, the younger generation?
Yeah. So I think, I mean, as perhaps as challenging as it seems, I think the trainees, they need to choose from the start, or they need to, from the beginning, decide themselves what they really want to do and direct themselves toward that direction. Yeah. So for example, I have trainees now, even on year 2 or 3, who decided, okay, I want to do gynae-oncology. Even if they need to go and do obstetrical duties, they can come in the evenings and assist me in my patients. In any complication, they can come in and assist me in the night. You know, that's how I learned. I went in every laparotomy. You know, of course, that beats every European work directive. But on the other hand, you know, you have to direct yourself towards a mentor who will teach you and who will guide you what to do. Go early enough to become member of the BGCAs, of ESGO, of ENIGOs, of all these societies, to get acquainted with other juniors in the field and exchange opinions, exchange experiences. It's really late if you just do an obs and gynae training, a general obs and general gynae training for, I don't know, 10 years, and then after 10 years of having had no contact to gynae-onc, suddenly you start doing a subspec training for 2 years and that's enough. This is impossible. Yeah. I mean, we are all so specialized now that we need, even as junior trainees, to from the beginning decide what you want to do. Yeah. And not after 6, 7, 8 years of 5,000 deliveries and then say, now I want to do gynae-onc. It's yeah. And you need a mentor. You need a mentor who will help you, who will support you, who will bring you into the pathways. You need somebody to guide you.
Thank you. I'm going to let Mirja now talk a little bit more about what you're very, very good at.
Great. Yeah, thank you, Effie. And again, yeah, an honor for me as well, for someone that I've heard so much from my patients, actually. So that's also very special. Just wanted to go into a little bit ovarian cancer, which I know is what you treat, and what, like you said, is kind of something that attracted you from an early stage in your training. So epithelial high-grade serous ovarian cancer is the 6th commonest cancer in women. I just wanted, for the benefit also of more juniors who are listening to us, maybe some patients as well, to hear a little bit about the presentation of this disease, how we generally manage it, and some of the outcomes that we see nowadays.
Yeah, so first of all, the landscape in ovarian cancer, especially in high-grade serous ovarian cancer, has changed massively in the last decades. Yeah, these women who would die within 2 years in the past, they now live many years. Yeah, they can even reach a decade sometimes. So it's a massive change what we have brought, not just on the surgical aspect, but also systemic advances. Interestingly enough, we haven't managed to change the cure rate, so less than 20% of our patients will be cured so far. I'm not really sure this will remain as low now with the new PARP inhibitors, but we have to see. Yeah, we just don't have enough data yet. But even though we haven't really managed to cure them, what we have managed is to convert it to a chronic disease so that many of our patients can live on and on and on and come back to us and give us more, and we give them more. So it's like a journey more than just in one-off disease. So we have understood much more the significance of genetic background of those patients. In the past, I remember when I was learning in the university about ovarian cancer, we're saying 5% of patients are genetically mutated. You remember 5%, and now we know it's 30. Yeah, it's completely different landscape, and half of them are even HRD deficient. So it's completely different profile and understanding. We know that by operating them more and more again and again, they can live longer by giving them more chemo and more targeted agent and more everything. Despite the relapse, despite the high volume of disease, they can do well. So it's exactly the opposite than what we have learned for other cancers. Now, in any other cancer, when you have peritoneal carcinosis, it's almost a death sentence, yeah? Whereas in ovarian cancer, you can still do things, debulk them, do more, despite the high volume of disease. It's like a paradigm shift, and we needed time to learn that, but I think we have learned that. And even in the UK, which is a very conservative environment, especially surgically, I think even here, we had a very nice BGCS session this morning where, I mean, you see how the whole landscape changes, and that is very, very interesting. There are some limitations in terms of, I mean, NHS is a restricted system now. We all know that. There are limitations in terms of ITU beds, theater beds, capacity in theater. This is something that will take a longer time to change. So we have to work within our limitations of the system and move things around so that, yeah, we're able to make it.
Yeah, exactly. Yeah, of course. And we will talk a little bit more about genetics later on. But I guess a lot of people would be wondering, do we have any effective screening tests for detection of ovarian cancer early? Because we talked about the cure rate that we have not managed to improve. So what's your knowledge and experience around that?
Yeah. So it's a very good question. So I don't know if you saw, there is a publication that just came out in Lancet Oncology or in Lancet like a week ago. It's the final analysis of the UK TOC study. I don't know if you have seen it. So you all know that, I mean, there have been many screening programs in ovarian cancer. There has been the American data, there has been the UK data from the UCLH, from Usha Menon and Ian Jacobs, and which were all negative so far. But the UK TOC study was only reporting preliminary results 4 or 5 years ago, and they said we need a few more years to see whether there is any difference. And the paper is now just published like a couple of days ago, and it shows absolutely no difference. Yeah, so even though, it was very interesting, even though I think 45% of the patients who were diagnosed in the screening arm, they had stage 1 and 2, as opposed to only 10-20%. And the patients in general were diagnosed in lower volume disease and lower stage and etc. Somehow this did not translate in any survival benefit. And that was a
Okay.
follow-up of more than 10 years. So I think this study has confirmed that screening in ovarian cancer is a bit of an illusion. Yeah, it's a bit different in genetically mutated patients. So if you have a genetically mutated patient, so it was the FQ UK talks, the patients with genetic background, where we see that serial ultrasounds and CA125, they can perhaps direct you a bit better, but we don't really have any survival benefit yet. And to be honest, I don't think there will be any more screening studies.
Okay.
Yeah.
Okay.
That's interesting, actually. Yeah, and we'll definitely try and find the publication and read it. Yeah.
Yeah, no, I can send it to you. I can send to you. It is here, UK Talks Final. I have it. It's in Lancet. It's published on the 12th of May.
Okay. Yeah. Yesterday.
Yeah, yesterday, exactly.
Yeah.
Yesterday.
Okay. Yeah. We'll try and stay as up to date with publications as you are. But yeah, we'll definitely find it and have a read. Thank you. So yeah, you've touched a little bit on genetics. So we know from recent advances and knowledge, we have an understanding that high-grade serous ovarian cancer there's a very significant role for the BRCA gene. And even though only a minority of patients have a germline mutation, many others have both somatic mutations in the BRCA genes or in the other homologous recombination genes and proteins, as you mentioned. So genetic screening for this BRCA mutation has allowed for improved preventive measures and therapeutic development as well. So would you like to tell us exactly the significance of a BRCA mutation for a patient? What does it mean for their outcome, for their treatment?
Yes. So yes, very, very good question. So we know that approximately 25% of patients, 25 to 30 with high-grade serous ovarian cancer will have some type of a BRCA-like mutation. These patients, we know that they respond usually better to platinum, they live longer, therefore, and they respond much better to the PARP inhibitors. The PARP inhibitors is a new targeted agent, yeah, if you want to call it in a simplified way. It's a targeted agent that practically works better in the patients who have a homologous recombination deficiency. However, this doesn't mean, we thought initially that it works only in the genetically mutated patients, but now we have understood and realized that they also work in the non-genetically mutated patients, and that is why NICE has now approved niraparib even in the first line in the non-genetically mutated patients. There are some publications from Charlie Gourley from Edinburgh that BRCA patients, when they recur, they often have a higher incidence of visceral metastasis, like true liver mets,
Okay.
or even brain mets, compared to the non-BRCA patients. I mean, I've had various BRCA patients with multiple liver mets who would be condemned to die years ago, and now they just get PARP, everything goes away, and then after 5 years PARP, they come with a solitary pelvic mass. I operate them, and then they live more years. So it's very interesting to see the change in the landscape.
Wow.
Yeah, it is definitely. And continuing on the topic of BRCA, so what is the role of preventive surgery in BRCA mutant patients in reducing the risk of ovarian cancer development, and what's things to take into consideration and as well when patients come to these decisions?
Yeah, so of course the only way to prevent ovarian cancer is to remove the ovaries and tubes, to remove the adnexa. Yeah, still, even if you do that, there is still a 5 or less than 5% risk of this so-called primary peritoneal cancer, which, to be honest, I don't really think it exists. It's just that probably there was a STIX undiagnosed at the salpingoforectomy that just had already disseminated some cells, and they were just staying there, and at some point they woke up. So because we know that the pathophysiology and pathogenesis of high-grade serous ovarian cancer probably it's from the fimbrial end of the fallopian tube and not of the ovary, there are some novel approaches now that in young patients that we do not do a salpingoforectomy, but we just do a salpingectomy initially, so that they can still, so that they don't go in iatrogenic menopause, and then they can have, after, at some point. So a two-stage procedure of removal, also the ovaries. There are multiple studies. There is a study of Ranjit Mahandra from the UCLH now that he's doing, so you probably know him. There are many Canadian protocols that are doing that. There were two very nice publications, posters, oral presentations in ASCO, in ESCO in Copenhagen in our virtual meeting this year. One was from Copenhagen and one was from Canada, I think, about Netherlands and Canada, about this two-stage approach, about the feasibility, quality of life, etc. Of course, these are all relatively new studies where we don't have long-term oncologic safety data yet, because you just need decades, to be able to see any difference. But I think this will be, the future, especially when if we really push it and we say these are the BRCA patients, we can say, okay, we take out early enough their tubes. So these patients, the women, they won't get pregnant normally anyway, because they don't really want to have the BRCA to their children. So they will do IVF with pre-implantation diagnostics, select the non-BRCA embryo. So you anyway don't need your tubes for that. You get pregnant, you have your children, and then you have the ovaries removed. If we want to put it in a very artificial but very scientific scenario.
And what sort of the optimal age that you advise your patients to go for these surgeries?
We say till 45. No, we say till 45 for BRCA2 is earlier, and it also has something to do with the age of the first relative. But we wouldn't do it longer than later than 45. I mean, it's tricky. I've had many women, not many, I've had some women who referred to me at the age of 60, 70 even, who had a new diagnosis of a BRCA gene, for which reason ever. And then they say, come, I'm here, I'm 60, I won't have my ovaries out. And you say, okay,
fair enough.
You haven't had ovarian cancer till now. And actually your age of preventative surgery is past. And if you go and have a surgical complication, then it will be out of evidence to do it. On the other hand, if they develop ovarian cancer later, it's all about what you know, no? It's about the torture of knowing. So
exactly.
So if we know somebody early enough that they have a BRCA gene, yes, at the age of 45, the latest. The question is, what do you do with the patients who come to you older than that, who just, not because they just neglected it and they knew it. I mean, if somebody knows it since the age of 30 and just comes at the age of 70, I wouldn't operate on her. The question
you just found out.
Yeah, the question is you just found out. So that's tricky. And you need to just weigh with them the risks and benefits.
Exactly. Yeah. No, and actually, the penetrance and when the phenotype presents can vary. You just reminded me, I think 2 patients who had germline BRCA mutations and they presented in their 80s with advanced cancer. So
exactly.
you just
absolutely. It's just about risk and risk.
And we can't predict that actually. And I'm also aware that you've been involved in pathways that have been put in clinical practice through the British Gynaecological Cancer Society about ensuring the timely testing for BRCA mutations for patients with a new diagnosis of ovarian cancer. So would you like to explain these pathways, but also what are the requirements really to set and establish similar pathways in smaller countries like Cyprus and Greece? Do you think that can be done?
Okay, so first of all, this is something new, no? So it's only news in the last years that in the NHS and even in Europe, for example, in Germany, we started routinely test all patients with ovarian cancer, or high-grade serous ovarian cancer. In the past, it was only according to your family history, but nowadays we know that more than 40% of patients with a BRCA mutation will not have a positive family history, so we can't really rely on the family history. And therefore, we nowadays just offer it to all our patients, especially since we have therapeutic consequences here. In the past, it was just about family. Now we have completely different pathways of treatment. So there were many, many discussions. I know I was involved years ago before I came here with Germany. Who will do it? Is it the state? Is it the insurance companies? I mean, every system is different. In the UK, it's now being taken over by the NHS, even though it wasn't really a very straightforward way. But I think it was the patient charities that also forced it in a way, and it's a good way to do it. In Greece and Cyprus, I mean, I've never worked there, but I know that the patient charities are not as strong as in the UK, isn't it? So I mean, the limitations and the money is in the public sector. We're failing sometimes in having blood for debulking, not doing a genetic test. On the other hand, the governance issues are completely different. I don't know how it is in Cyprus, but in Greece, in Athens, you can just walk in any genetic institute and say, hey, take blood, I want to find my BRCA status, without any genetic counseling before.
Mm-hmm.
Isn't it? Probably it's like that in Cyprus. Here, you need to pass through 10 filters to be able to have a genetic testing because of governance reasons, so it's just different ways of approach. In terms of money, I think there is a lot of there is now a lot of awareness around the genetic background of diseases. Even in endometrial cancer now, we have published within ESCO and ESTRO the new guidelines where we treat patients according to their molecular profiling, etc. So it's not anymore just the histology that defines the disease. So I think even in countries like Greece and Cyprus, it will be a standard pathway to do a genetic testing for the patient.
Yeah, I think you need sort of a healthcare system that's kind of homogeneous in your whole country, I guess. Like you said, I know you've also actually reminded us of the power of patient groups and charities. I think we've kind of discussed that in some other conversations we had through the Cyprus Medical Society. So kind of shows the power of patients and their representatives.
Exactly. I think we need to empower. I think in countries like Greece and Cyprus, we need to empower the patients more. We just need to empower the patients more.
Yeah, exactly. I definitely believe in that. And there's a final question for me from this section before I move on to Effie. So we did mention what BRCA mutation means, so significant implication for response to chemotherapy, but also for further sort of maintenance treatment and different survival outcomes. So definitely change the course of this disease. How do you see them being used in the future? And do you see that it changes what you will do as a gynecology oncology surgeon for these patients? Do you see? Yeah.
So there are two views to see that. There are two ways to see that. One way is usually some conservative approach. The conservative approach is to say, BRCA patients, they respond so well to platinum, they do so well anyway, so why do you bother operating on them? Yeah, especially at relapse. That's the one way.
Mm-hmm.
The other way is these are the patients who will live the longest. These are the patients who will respond mostly to our treatment. So these are the patients who will actually benefit from maximal effort treatment approach across all pathways.
Mm-hmm.
And we know in all BRCA studies, the patients with the PARP studies, the patients who were operated tumor-free had actually a better survival with PARPs than those who were not operated tumor-free with PARPs again.
Mm-hmm.
It's not like PARP can replace successful surgery.
Exactly.
What like surgery cannot replace PARPs. So it's about the package of care currently that is important. It's doing the maximal effort across all levels. And that is, I think, what the message is.
Yeah,
great. Thank you. And Effie, over to you.
Yeah, so Prof, moving on from what you've just said, like Miriam mentioned, we have reached out to a very important patient group in Cyprus, Europa Dona, and I know a lot of their patients are watching tonight. And so for our patients, let's talk a little bit about advanced epithelial ovarian cancer. We know the standard treatment of patients with stage 3, stage 4 epithelial ovarian cancer is a combination of primary surgery followed by chemotherapy. So in the recent years, like you just mentioned, it became very clear that the goal of the surgery is to achieve no macroscopic residual disease, because we see that the survival of these patients with no residual disease is superior to those where residual disease is apparent. Talk to us a little bit about your clinical practice, about maximal cytoreductive surgery, otherwise referred to as ultra-radical surgery for advanced epithelial ovarian cancer. And just in terms of the ideal patient, surgical complications and challenges,
Yeah.
and what the significance is for further systemic targeted or cytotoxic treatment once we treat them in this way surgically.
So very, very good question. First of all, what I would like to say as an appeal, especially since many of our Cypriot patients hear us, is that unfortunately, as opposed to the UK, in many countries like Germany, like Greece, like Cyprus, not only gynaecologists are allowed to treat patients with ovarian cancer. So there are many patients with ovarian cancer who will go to their normal gynecologist who delivered them, did their fibroid resection, and then they trust him or her, and then they will go and do their ovarian cancer surgery. The patients will not know better just because they don't know better, just because nobody told them. The doctor feels embarrassed to send them to somebody else because they know this patient for years, because as you know, every Greek and Cypriot woman has her own gynecologist, so there is these patients are being not treated adequately by not going to the right team. And the even worse is that because very often ovarian cancer affects the bowel, instead of going to a specialist gynecologist, they go to a general surgeon who will then treat these patients the same way like he or she will treat a colon cancer, pancreatic cancer, gastric cancer. So I have so many second opinions from Greece and Cyprus of patients being ill for 4 or 5 years and they never have seen a gynecologist, never, which is actually dramatic nowadays. So what we need to make our patients understand is that there are now specialized gynecologist who are dedicated for the treatment of ovarian cancer, and it is their right and it is the obligation of their doctors to send and refer them to the right person, not to a general surgeon, not to a colorectal surgical oncologist, not to a general gynecologist, but to a gynecologist. Okay, so that is an appeal, and I think we need to really get the message across. Because much more than the technicality of the stripping of the peritoneum plays the tumor biology, the philosophy, the understanding of the concept of the whole disease. Okay, so ovarian cancer, as I say to my patients, is a disease of the peritoneum. It's a disease of the skin of the tummy, and this disease, it's like a rash. So imagine you have it's like having a cup full of sugar or sand and throwing it into somebody's abdomen, okay? So in order to be able to treat this, you can't, of course, take your scissors and take every little nodule out. You have to strip the peritoneum like you take off your gloves or your tights. And as simple as it sounds, it's actually, if you know how to do it and if you follow the streets of the abdomen, it's easy. It can be done without being scary. And because humans are born to survive, within 8 days to 10 days there is a new grown skin. So the peritoneum, it's like cutting off a part of your hand, of your skin of your arm. It will grow again in a few days, and the same is with the peritoneum. And this is why ovarian cancer comes back again, because it comes back in the new grown skin. So the majority of these operations, these are called cytoreductive operations, so reducing the tumor burden, is to strip away organs. And if you can't strip away some organs, you might need to resect a part of these organs. However, we have in ovarian cancer limits of what you resect so that you don't actually affect the quality of life of the patients. What do I want to say with that? You would never remove the entire small bowel of a patient so that she doesn't have any small bowel to live anymore. You would never remove the entire stomach. You would never remove the entire pancreas. You would never remove the entire liver. So yes, we might remove the spleen, fine. You need a vaccination after that, it's fine. Yes, we might need to remove, half a meter of 8 meters of bowel. Yes, we might need to strip the right diaphragm, and we might need to strip the liver capsule, but we never really remove life important organs. If we see that the disease has gone so extensive, we stop, we step back. And that is why approximately, in experienced hands, approximately 65 to 70% of our patients will be operated tumor-free. And the rest cannot be operated tumor-free. It's not just because the surgeon wasn't good, it's just because the tumor dissemination and biology of the disease dictates that. So even if this operation sound scary at the end, they're surface operations. Yeah, they're surface operations. In terms of morbidity, we have done extensive studies now to study the morbidity and also the quality of life post-surgery. I remember my old chief from Austria used to tell me these patients, they need a year to recover, not from the operation, but from everything. You hit them with surgery, you hit them with chemo. And now we have done so many quality of life studies. And one of the most important studies is the SOCA study from Sudha Sundar from Birmingham, who has really shown that. So the quality of life immediately after surgery, the first week or a month, is less, of course, than before the operation. However, at 9 months, it is higher than before the operation. So the patients will need around 6 months of treatment, surgery, and chemo. And a few months later, so 3-4 months, a bit to recover. So 9 months from initial diagnosis, the quality of life will not be as before, will be better than before in terms of diagnosis. Yeah. So this is the journey. And I think it's very important to tell that to the patients from the beginning, so that because sometimes they feel that they're doing something wrong, or that they're not fast enough. So they need to know how, that this is a journey and how long time it takes to recover. Not just the operations, everything. They're being hit repeatedly, no?
Yeah, I think this is so important coming from you, especially. You've obviously seen a lot of patients. And I think for our patients tonight, it is really important to understand the challenges that both the surgeon, their doctor will face, and that this is a journey that they are making together rather than them on their own. You've touched upon some of the challenges, such as the appropriateness of the surgeon themselves. What other challenges? I mean, and I think that's a very, very important one. I think definitely in Cyprus, we are in that category of countries where that seems to be the norm. What other challenges are gynecological oncology surgeons facing with this nature of metastatic disease?
Yeah. So I think the most, so that I give you an example, yeah. So I was working in the Charité, and I still had a chair there till I still have now a honorary chair. I had a normal chair till a few months ago. The hospital, the Charité hospital, it's one hospital, yeah. There are 3 campuses, but in the hospital, in the Virtue Clinicum where I was, they have 300 ITU beds, 300 ITU beds, one hospital, okay. In Imperial, which is one of the largest cancer centers, we have, Nick, how many? 13.
I was about,
yeah.
It's impressive.
It's massive. It's a huge difference. Yeah, and now with COVID, Charité said, oh, they don't have enough ITU beds. They made a whole parking space with 100 more. So they had 400 in one hospital. Yeah. So, it's so ITU. Yeah. In Greece, I remember my father was ill and he needed to have a surgery, and I needed from England to call relatives to go and spend blood and donate blood. Yeah. In Greece. That was 2 years ago. Because we have blood banks, but not everybody is donating. They just donate for. It's also the mentality of the country, yeah, and of the people. So I think one of the main limitations and problems of the challenges that the gynaecologists face is the infrastructure that they have to work in every country that they have to work in. Availability, medical legal implications, yeah. So these are huge surgeries, and this is a journey. So you really need to love what you're doing to go and jump into the cold water with your patient. And what I always say to my trainees is, if you want to have a nice life, don't do gynecology. Don't go and do IVF. So it's a profession that really needs dedication. It's not adequately reimbursed. Yeah, it's not. If you see the insurance companies in these big set reductive surgeries, they reimburse the hysterectomy and nothing else. Everything else is for free. So this means that practically, and the same is the reimbursement for the hospital. So people at some point say, good, what is the reimbursement in that? And then they say, okay, then I don't have enough ITU beds, enough theatre time, enough money that is being given. To give you an example, I have in the UK many patients from second opinions from all over England, okay? And NHS England used to pay the hospital extra for every second opinion patients would see outside of our catchment area. And now they stopped that. So no matter if I operate 100 patients more from all over the country, we will get the same amount of money from NHS England, like as if we operated only from our catchment area. Then the managers come to me and they say, hey, Christina, you operate all these complicated patients from all over the country. They have to stay longer because they're so complicated. You take up theatre time and we get nothing from that. Why do you continue doing that? And what is my answer to that? You know, so it is very, very tricky, very tricky. That is why there is a trend now, or there will be a trend, that there will be supra-regional cancer centers. So we have like 40, 50 cancer centers all over the country who do everything, yeah, but that we just choose 10 of them to be supra-regional cancer centers for this radical debulking surgery, so that they have extra NHS funding for ITU, for theatre, for blood, for nurses, for everything.
So there's very few centers around the world, like the Charité, like the Hammersmith, that have this amount of experience in this area of cancer management.
That is true. That is true.
Yeah, and it takes a lot of expertise, a lot of training, organization and infrastructure, like you said, to create a center of excellence similar to these. And you've worked at both. So this is not possible in all countries. One such example is Cyprus.
Yeah.
How can the clinicians in countries like Cyprus, like Greece, optimize the care for their patients?
So Greece has 2 centers of excellence, according to ESCO, one Thessaloniki, one in Athens, and I think it's fine too. Indeed, Cyprus doesn't have one. I'm in close collaboration with many of my Cypriot colleagues who just pick up the phone or drop me a WhatsApp or a text and ask me. And I think it's very important now in this time of virtual world that we all live in. It's so easy to just pick up the phone and ask for an opinion and advice. Yeah. And nobody should be ashamed to do that, and nobody should be too busy enough to answer. Yeah. I mean, sometimes people just need guidance, and then they will do the right thing. And the more guidance you give them, the more experience they will get. There is no discussion that if it is a complicated case, yes, these patients need direct referring pathways, like they comment. I mean, the Cypriot embassy, they will send this to Imperial. The oncologist directly will send them to Imperial. We will treat them here, and then they will go back. And it's so easy. I mean, forget the COVID now, but it's so easy. Yeah, sometimes it's easier to take a plane to London than to just go from one city in Cyprus to another. Yeah, just because the world is now so small, apart from the COVID pandemic. But yeah. And it's, you know, in the past we said, oh, you will go and have your surgery somewhere else, and then who will pick up with the problems afterwards, and your oncologist, will they be on board? Now we are all one team. I am one team with the Cypriot colleagues. I just pick up the phone, or they pick up the phone, and I say, hey, I just operated today. She will fly back to you next week. You can start chemo the week after. So it's also, we are all such in direct communication that the patient shouldn't worry that they will have disruption of their care. They will not. Just because it's so much easier for us to communicate. We even do MDTs across countries now. Yeah.
Really glad that you consider the possibility.
Yeah.
Because I think if there was appropriate and timely referrals, even patients in Cyprus with advanced ovarian cancer could receive just as good care.
Definitely. And there are so good oncologists there, and so good also gynecologists who really know what to do. I mean, not everybody needs to know how to strip the diaphragm. We are happy to do it, and then the rest they can do. Yeah. And we just work together. And these pathways, they are now so well designed and simplified in compared to the past. Yeah. So patients should feel reassured about this.
Good.
Yeah, Good to know. I mean, you've touched a little bit on MDTs actually. So my next question was, what is the role of centralization of care and decision making within a specialized MDT for the management of gynecological malignancies?
Yeah, no, I mean, it's no discussion anymore that these patients need an MDT discussion. Yeah, even I, where I'm supposed to be a key opinion leader in the field, I will never just decide, hey, let me operate on you. I will pick up the phone, talk to my radiologist. Yeah, I will have a specialist radiologist who will only look ovarian cancer patients, images the whole day. We will go through the images together. I will then ask my oncologist and discuss the pathways, and then we will say we operate. So no matter how an expert you are, you can't possibly do everything on your own. And nowadays we only treat patients within MDTs, or this is how it should be done. Yeah, there is no discussion that there are still many arbitrary decision-making processes still, and even in countries like the UK with a very well-established MDT. I mean, we did together with GSK, yeah, with GlaxoSmithKline and some other people from the UK, like Jonathan Leatherman and Sundar and Rohan Miller. We did, initiated by GSK, but still we helped a discussion and interview of different healthcare professionals about MDT and access to MDT, etc. And even though almost everybody means 99% said the patients at initial presentations, they always get referred to an MDT and being discussed on the MDT. Less than half of the patients will be discussed on an MDT down their pathway at the second or third relapse. Less than half. This means the oncologist just sits in a small room with a patient and says, you have a relapse, what shall we do with you? Let's give you some chemo, or let's do some palliative care. Even in the UK. Yeah. Why do these patients not benefit even further down their lines from an MDT approach? So we should, all of us, just go away from this, we decide, it's one person deciding. On the other hand, you need to have experts in the MDT. The MDT per se doesn't give a blessing. Sometimes if you have 10 non-experts doing an MDT, the decision will not be good. So you need to have the right people sitting in this MDT. And sometimes it's just a medical legal box, this MDT, so that is also not right. Yeah. So it needs to be a balance.
Exactly, yeah. No, and I think we just educate each other through an MDT as well. I've seen, patients coming directly from the gynaecology surgeons, or also in my breast cancer jobs when the BRCA testing has already been done, because we all work as a team. It's not, it's part of the whole MDT to kind of look after the patient, and ultimately you're looking after your patients better. And just because we talked a lot more about radical surgery for at the initial stages of diagnosis, so in terms of patients who recur, would you like to talk to us a little bit about surgery later on, about palliative surgery? What can we achieve?
Yeah, so we knew that for patients with primary diagnosis, the more you remove, the better the longer the patients will live. However, we know that once ovarian cancer comes back, it will always keep coming back. You can't really cure these patients. That is why there was a way of nihilism of seeing those patients. And many said, why do you bother operating on them at relapse, since they will anyway recur? So we had a lot of retrospective evidence showing that even if you operate at relapse, they will live longer. But we didn't really have it in a prospective way. So we did within the Europe and UK, the multi-center desktop study. The desktop study is a study according to which patients were operated. Half of them were operated and given chemo, and the other half were just given chemo. And they were compared who did better. And we saw that those patients who were operated, especially those who were operated tumor-free, had not just a significantly better progression-free survival, but also a significantly better overall survival. And it was that even those patients who relapsed, if they could be operated tumor-free at relapse, they had a median survival of 15 months longer compared to the non-operated patients. It's more than a year. I mean, which drug achieves that? Yeah,
True.
Which drug? One drug? Nothing. Yeah. So that is why we now have redefined the role of secondary debulking in ovarian cancer. We have now we operate now, for example, I operate currently at Imperial a lot of Scottish patients, even though Scotland does not belong to NHS England. So usually they wouldn't refer to us. But because of the pandemic and because of the new regulations, they don't have a lot of theatre time. The Scottish patients, many of them are being referred to me down at Imperial to operate on them as a new way of thinking and as a new way of approach. So this will come more and more.
So you touched a little bit on how COVID has affected your job.
Yeah.
How has it affected the management of our patients? Has this experience with COVID this year potentially given us also the opportunity to trial new ways of managing ovarian cancer? And can we learn something positive from this year?
So good, your question, so good, because everybody only talks about bad things. So I think one of the most important lessons from this pandemic are the virtual consultations. Yeah. So that's so, I don't think we will ever go back to the way it was before. Yeah. Patients have much more direct access to their treating teams now, just because in the past you needed to go and see somebody, whereas now everybody has a link, a phone number, and suddenly all governance problems that were existing in the past now are away, and they can just, everybody has access to anybody for a virtual consultation, and especially for foreign patients, it's very important. Yeah. Then the radiologist now can review their scans from home. So I have access to an expert radiologist anytime. They can be at home. I can pick up the phone and say, hey, what do you think? And they can reply to me. Whereas in the past, they needed to go to the hospital, open the system, see the, so it's just everything so faster now.
Yeah, absolutely.
So I think this is what the pandemic has shown us. Even patients who, who would be too ashamed or wouldn't want to come to a hospital now, regardless of the pandemic, now they can pick up the phone and do a virtual consultation while being at home. Even older patients who don't have a son or a daughter to bring them to a hospital, simple things like that. So this is something that the pandemic has taught us, that it is actually safe to do virtual consultations.
One final note, Professor, because unfortunately, although we have a lot of questions, we are limited with time.
Yes, I know.
How do you feel oncology is changing as a specialty? How is it evolving, and where do you see us in 20 years from now?
Yeah. So, gynaecology in general, not just ovarian cancer, it will change massively. So we have in many trends, in many cancers, women's cancers, apart from ovarian cancer, a trend towards a less radicality and more minimal invasive approach. These big, huge lymphadenectomies that we used to do in the past are now being replaced by sentinel. These open big surgeries that we used to do in everybody are being largely replaced by minimal invasive surgery. Yeah. Patients on the other hand, we will as professionals be faced with a much more challenging profile of patients, in that you can't say anymore to the 85-year-old, you're too old to be operated. Yeah, you can't. You just can't.
Very true.
You just can't. So, or you can't say to the 180-kilo patient with endometrial cancer, you're just too heavy, too big to operate on you. So the patient's profile changes. We as clinicians now have to treat them. We can't say it's too old, too advanced, So the patient's profile gets more complicated. So we need to adapt on that. So I think our profession will become easier in some ways, but also more complicated in some others.
Exactly. We shall see. Professor, you've got a lot of decades ahead of you, and I'm sure you'll see the difference as well, and we will see the difference together. Prof, thank you very much for your time today. I've learned a lot of things, and it was great to see you as well after a few years, even virtually. I think you have added a lot of knowledge to the people that have watched us and the people that will watch us in the next few days whether that's junior doctors, medical students, or patients. And I'm sure that there will be some junior doctors, some medical students that will be inspired by you and might want to follow your career pathway. There's some people that might not be encouraged as you, because it's a hard job, what you do, but it was great to have you, and please, I'd like your comments.
No, it's my honor and my pleasure. I just want to say also to the patients or to the doctors from Cyprus who listen to us, I'm only an email or a text away. Yeah? I'm very happy. I mean, there are other people can wait for days till I reply to their emails, but if a patient or if a doctor emails me for an advice, I will reply like within immediately. Yeah, I will never be too busy to give advice to a colleague or to share experience with a colleague, yeah, or with a patient who wants to see me. So yeah, just I would be very happy to help anytime.
Thank you. That's amazing. That's quite inspiring. I don't know, Miria and Effie, would you like to add anything as well before we close?
Yeah, no,
Miria, you go.
just wanted to say thank you, and thank you for your dedication to these patients. Actually, it's very much appreciated from myself as an oncologist, and I'll just leave Effie as well to say something.
Yeah, so same as a hopefully gynaecology trainee someday and subspecialist, I would definitely, I feel like you've added a lot in this hour to me personally, and also it's very humbling for us that you talk about Cyprus, and you're so willing to support the doctors in Cyprus for our patients here.
Of course, we are all a team. It was a pleasure to be with you. I send to Cyprus all my regards, and hope to see you again soon.
Thank you.
Thank you.
Bye.
Bye bye.